I'm Jason Shire, and welcome to Quick Gastro. This is a video on the internet, so we shouldn't be using this to diagnose or treat people with medical conditions. Read the fine print, but mostly this is just for education. This is where we help physicians in training understand inflammatory bowel diseases, including Crohn's and ulcerative colitis, to better serve the patients that trust them with their care. Today's topic is going to be how to pick which of our many therapies is most appropriate for your patients. We're going to go over some different strategies and help you understand what your options are. In 1955, you had sulfasalazine and prednisone. How hard was that? But with so many medications available, how do you know which one is the right one? We have a vigorously studied and vetted algorithm of treatment options that I'm just kidding. The insurer largely tells us what to do. But sometimes, we do get to make the call. And there are several factors that go into choosing which agent is the best agent for that person. After sulfasalazine came to the market, it was followed by steroids and immunomodulators. 1998 marked the FDA approval of infliximab, and with it came the age of biologics. First, we had several anti-TNFs. This was followed by anti-integrins and anti-interleukin 12-23s. Now we've entered the age of small molecules. And the use of these medications in patients is largely following this timeline. This is called step-up therapy. The theory is that we try less expensive or smaller medications, and then we move on to the big guns. This may also follow costs of the medications. But let's talk about the phrase big guns for a second. Just because a medication is more effective doesn't mean it's associated with more side effects. In fact, many of these biologics are safer than the steroids that preceded them or the immunomodulators. When a patient or doctor starts talking about these medications because they're afraid, our job is to educate them about the benefits and the risks so that they can make an educated decision. So let's stop using the phrase big guns when we're talking about these medications. The opposite approach is to put the patient on the most effective regimen first and titrate down when in remission, with the hopes of inducing remission quickly so they don't suffer for months or years while we try various regimens, maintaining them without flares so they are not on prednisone, in the ER, missing work, or away from their family, and avoiding long-term complications such as fibrostenosis, penetrating disease, and surgery. This increased effectiveness comes with increased short-term costs, potentially exposes the patient to more side effects, and may have some patients on medications they don't need. And which is the better method to use? This study looked at step-up therapy in the form of conventional management compared to top-down therapy in the form of combination of anti-TNF and immunomodulator therapy. It found that at 52 weeks, top-down therapy was clearly superior because more patients were in clinical remission. Although it seems that at 2 years the p-value isn't significant anymore. And for those who advocate for step-up therapy, at 2 years, those patients were on less medication. And steroid-free clinical remission is even more confusing, because at the end of 2 years, whether you were step-up or top-down, there's no difference in outcome for steroid-free remission. But if you prioritize early steroid-free remission, then top-down was again clearly superior. So what's the right answer? It just depends on what you prioritize. If you think steroid-free remission is the most important, well, we have an option for that. But if you're worried about side effects or cost of medication, then maybe there's a different medication. Me personally, I prefer clinical remission, because if we hit all the other benchmarks but the patient doesn't feel better, then we really didn't give them value with our therapies. Which brings us to our third option for how to pick medications. What if I told you I don't actually know what the right medication is? Sure, I can make a guess, and maybe my guess is better than some, but I don't actually know what's going to happen. In fact, I think it's like bird watching. We know where we want to start, and we know what we're looking for. We give it time, but it just doesn't show up. So we make some changes and reassess. Eventually, we reach our goal, and everyone thinks that we're a great doctor. Bird watcher. In IBD, this approach is called treat to target. We're going to try to stratify people based on their risk of long-term complications. We're going to pick a therapy based on which one we think is going to be most effective for them. We're going to draw a line in the sand and assess at a certain time period if they are in remission or not objectively. If they're in remission, we're going to continue that therapy, and if they're not in remission, we're going to make changes until we get to that point. This approach was tested in the CALM trial, where they took people living with Crohn's disease assessed them as having moderate to severe disease, put them onto adalimumab, low-dose therapy, and put them into two groups. One group was managed by expert IBDologists, and the other was mandated that every 12 weeks they assessed for remission and made changes if they weren't in remission. Those changes would be to either adjust the dose of the medication or add an immunomodulator. What they found was at the end of the study, 50% more people were in remission with this aggressive endpoint-driven protocol. And while the improvements in outcome were seen across all endpoints, they were able to increase deep remission using this approach. And when we look into the data to see what actually made the difference, the group that had mandated changes to the regimen if the patient was not in remission was on significantly more medication. So to say it another way, dragging our feet with small improvements that do not meet remission is more likely to leave the patient with active disease. And setting benchmarks in endpoints and time is more likely to achieve the goal of remission. So let's wrap this up with a summary. I don't know what people will respond to. Our understanding of Crohn's disease and ulcerative colitis are not that elegant. If the patient has mild disease, using Stepup therapy is appropriate. Often the insurer directs care and uses a step-up approach based on short-term cost analysis. If we feel passionately that the patient needs a more effective therapy, then we should try to pick the best therapy for them based on the severity of illness and any contraindications to other medications. Regardless of what agent we pick, the most important thing is to set a goal of care, often combining clinical and objective endpoints. Then we decide how long it will take for medication to work based on the time to maximum effectiveness. If the patient's not in remission at that time, optimize the regimen to achieve that endpoint and start the clock all over again. With this approach, most patients find significant improvement in their quality of life. The IBD stops being something that defines them and starts just being a thing that they have. Thanks for watching. I hope this helped you understand different treatment strategies in IBD, and if you like it, please share it with your peers. Be good to each other.